Developmental hip dysplasia is one of the most common problems in pediatric orthopedics. It is often referred to as DDH. As with any childhood disorder, parents can find the diagnosis troubling and seek more information. This video is created to reduce anxiety surrounding the diagnosis by educating parents on hip dysplasia and giving perspectives from parents who've gone through the same process. First, we will talk about what hip dysplasia is and what to expect. Then we will give advice from parents and providers on how to best take care of a child who has DDH. DDH is a spectrum of hip instability. In order to pass through the birth canal, babies have flexible joints. When this increased flexibility results in hip instability, a baby is said to have DDH. Here is a model of the hip. The big thigh bone is called the femur. The femur has a ball on top called the head. The head of the femur rests in the socket of the pelvis called the acetabulum. Mild DDH is when the hip joint is a little loose. Moderate is when the head of the femur can easily slip in and out of the socket. More severe DDH happens when the hip is dislocated at rest, and there might be a difficult time getting the head of the femur to stay in the socket. Another form of DDH is the actual dysplasia component. This is where the ball and the socket are misshapen and don't match together perfectly. DDH can happen to one or both hips. The risk of DDH is increased in firstborn females, babies who have undergone a breech delivery, and those with a positive family history. It is important to catch and treat DDH early, because untreated DDH can lead to early arthritis, hip pain, reduced range of motion, leg length differences, and disability. DDH is often caught on a newborn screening test or pediatrician exam within the first month of life. As the baby's hips are made mostly of cartilage rather than bone, this exam does not hurt your child. Barlow's test looks to see if the hips are loose or dislocate easily. The doctor will flex the hip and move it to the midline and then press downwards. Here you see a stable hip, a loose hip, a hip that slips in and out easily, and one dislocated at rest. In a test called Ortolani's test, the doctor looks to see if the hip is dislocated at rest. Here the doctor flexes the hip, pulls it gently outward and upward, feeling for a click. If there is a click, that means the hip was dislocated, and the doctor put the hip back into place. If only one of the hips is dislocated, the doctor may also notice that the length of the child's legs are different. If your pediatrician thinks your child has an unstable hip, they will send you to see a pediatric orthopedic surgeon, and you may have additional testing such as an X-ray or an ultrasound done. At the orthopedist's office, they will look to see if your child's hips are in or out of place and decide on the next steps. Fortunately, most early cases of DDH resolve on their own in the first few months of life. This early time frame is called the watch and wait period, where the doctor checks periodically to see that your child's hips are beginning to stabilize. In the first 6 months of life, if your child's hips need a little extra help, the doctor will have them wear a Pavlik harness. This harness keeps your baby's legs in a safe position where they can heal. If the hip has trouble staying in using a Pavlik harness, your child may be placed in a more rigid brace called a rigid abduction orthosis. This is a simple brace that holds the hips out and keeps them stable. If your child has their initial diagnosis of DDH after 6 months of age, or treatment with the Pavlik harness or the more rigid brace is not successful, they may need treatment in the operating room. The first stop is called closed reduction. In a closed reduction, your child will go to sleep and the surgeon will put their hip back into place with intraoperative X-ray imaging. There may or may not be a minor opening made to help loosen structures that are straining the hip. Once the surgeon has the hip in place, a protective spica cast will be put on to keep the hip stable. This cast may stay on for 3 to 4 month cycles. If the hip does not stay in place with a closed reduction, your child may have an open reduction. In an open reduction, the surgeon will make an opening in the hip and move anything that is preventing the hip from staying in place. A protective spica cast is again used after the surgery to keep the hip in place, and may be used up to 3 months. The cycle of spica cast can continue up to 18 months of age. In rare cases, these treatments are not successful. In that situation, a corrective surgery called an osteotomy might be done. In this surgery, the surgeon reshapes the pelvis or the head of the femur so they fit together better. Now you know all the main treatments used for DDH. The good news is that the overwhelming majority of children can walk, run, and play like normal after getting treatment. Here are some parent and provider perspectives on common concerns such as managing diapering, sleeping, feeding, transportation, and everyday life when your child has DDH.
If you're a parent who has just found out that your child is diagnosed with DDH, it's very important to absorb as much information as you can about the diagnosis, but then know and feel comforted that your child is going to be a normal child. They will develop normally, they will be able to still run and play and have a good time and be with other children.
So my daughter was diagnosed with bilateral hip dysplasia. She was probably 19 months when we actually diagnosed her, and of course she didn't know anything. She was actually walking by the time, running around, but we noticed there was something wrong with her, and so we tried to pursue what it was. We went to her pediatrician, and actually the pediatrician had sent us to a physical therapist, and the physical therapist is the one that pointed out that we probably should check her for hip dysplasia, and so they sent us to an orthopedic doctor, and after that they sent us to Vanderbilt. Pretty much went to surgery about 3 months later from when we were diagnosed, and that was actually, her first surgery was on my birthday, so it was a little bittersweet because unfortunately first surgery ever for her, and of course so I didn't really get to celebrate much, but she came out of the surgery in such good spirits and so happy, and that actually probably was one of the best presents I could have gotten, because I knew that everything was going to be fine after that.
They told us that we were to have to have an open reduction, which was go in and do more surgery than what she actually had. We were freaking out. She's been a week without the brace, and within a week she can stand up by herself with me holding her hand. She can hold my hands. She's got up on her hands and knees and started rocking back and forth. She's just progressed a lot, you know, and we have triplets, and the other two are not getting up on their hands and knees and rocking back and forth. So I feel like she's exactly where she needs to be. I don't feel like she's behind at all. And all babies are different, but we're happy. We're very content. With her being a preemie and up on hands and knees at 8 months, we're content. We're very happy.
The reason for the Pavlik harness is to hold the hips in position, which is why you see this funny little harness here. Most kids, typically when they're younger, it doesn't bother them as much. If you think of the ages, if you think that they're newborn or a few months old, they'll get used to wearing this harness. They'll get used to playing and still interacting and engaging just like they would without wearing the harness. We just want to make sure that we're keeping the hips in that position to help them to heal. A good thing for any parents that have children wearing any type of restrictive brace or cast or anything like that is to make it fun. So you can create your own clothing to go over it or underneath it. Onesies are usually pretty easy to slide underneath. And then you can also cut clothing if you need to on the sides to make it easier to put on and take off. But kids really adapt really quickly. If your child ends up having to be in a spica cast, which we have a little spica bear back here, like I said earlier, kids adapt quickly to having a spica cast on, and they'll actually learn how to play with their spica cast on. They'll learn how to lay on their stomach and crawl, or some kids I've heard have done little turns on the floor on their stomach. They learn how to spin themselves around. Kids adapt really quickly, and they're actually very safe and protected in this cast as well.
Clothing, since I had a girl, obviously it made it a little easier because I just went out and bought bigger dresses, pretty much a size to 2 size bigger. they had more like an empire waist, so it was a little higher that could flow out, so it kind of went down and around. It wasn't anything tight. Her Halloween cast, she was a witch, and so for Halloween, because we had the orange and black, and so people thought, oh, she has her Halloween costume on, like, and so all the kids were just like, oh, you know, I wish I could have that. And it was like, oh, well, hopefully you don't ever have to have a cast like this, but if you do, you can have some good colors. So.
The way that we want you to keep the cast clean is by using multiple diapers, and you can actually take off the diaper. I want to show you what's underneath. So there's a bigger diaper that you want to put over the top, and then we also have a smaller diaper that you can tuck up underneath the cast here. Sometimes you can actually use a sanitary napkin or a pad and put it inside here, and that way if it's an older child who is going to be more than a younger child, you can capture some of that in a pad so that it's protected, so that the urine doesn't actually get on the sides of the cast. There is a Gore-Tex liner under there, so if that does happen, you can use wipes and gently wipe underneath and on the sides to clean. But it's really helpful if you have either a sanitary napkin here with a diaper that you have tucked up underneath, like this, as far as you can get it to go. Sometimes you can use a sanitary napkin and stick it from the top up here down and just attach it, and sometimes that can help as well. And then you want to make sure that you cover this up just to help keep any other urine or feces from getting through. The main thing with having the spica cast on is that you want to keep up changing the diapers as soon as possible so that you don't have the sides of the cast soiled with urine. That can cause skin breakdown, so you just want to make sure that you keep on top of it.
So diapering probably was one of my biggest concerns. You're gonna have, unfortunately, urine get on the cast. It's just gonna happen, but you can go in and wipe it and take a hair dryer, and there's also, you can do some baking soda. That also can help relieve some of the odor if it is, because sometimes if you're in the cast 6 weeks or so, it's not going to smell good by the end, no matter what you try.
Changing diapers was, what I always did is I got the same size she wears now. Like, she was in a 2 at the time. She wore a 2, and then I would just tuck it into the cast all the way around, and then I would cut the Velcro stripes off of it to tuck it in so it wouldn't catch on anything. And then I always put a bigger one over it, so a size 3. Now the size 3 would last, a couple of days before I would change it until the Velcro started, because it would never get wet or anything. But the one inside, change it like a regular diaper. Dirty diapers, you want to check them more often, because in case it is a dirty diaper, it's going to go up in the cast, and that can cause a problem.
The first week was...
She was a tummy sleeper, so at first that was one of my other concerns, because I was worried that she'd have to sleep on her back, and at her age, when she was 19 months, like, all she slept was on her belly, so I thought, oh gosh, it's not going to be good. So we actually took a pillow and laid it down and kind of had her like lay on it, so make it a little, give it a little bit more support underneath. And she was fine with that, and now, even in the cast now, we don't actually, she'll just roll over and do everything she wants with it, so it doesn't seem to bother her at all.
I took like one of her little blankets and made a tight roll and actually bound it so it wouldn't unroll, and then we created like a little bit of a U shape that would kind of go just under here and not come up any further than that, but it would kind of support her legs.
I used a memory foam pillow to lay her on at the beginning so she could get used to it, so it wouldn't, like, the cast wouldn't push it into her, have a pressure points and stuff like that. Out of the triplets, she is the crankiest, the hardest to keep content, so on and so forth. And actually, I think the cast has actually calmed her down a little bit. She's not as cranky and stuff as she was. She's easier to keep happy.
Having the spica cast, it isn't a normal position that you would have your child in. So we do have our physical therapist here who will come in and actually measure and help fit your child into a car seat, so that we have special bracing that holds your child in the position in the car seat like this. So we don't just send your child home without anything to protect them in a normal car seat, because that's not appropriate for the spica cast on.
Unfortunately, because she was so old, Vanderbilt had a policy that we could not give their car seat. So that was something that we were really hoping to have. So we actually had to put her in, basically it's like a harness, and she had to sit and lay down in our back seat of our car with this harness on. So at first it was a little frustrating because she didn't understand, why am I laying in the back seat and it's a little uncomfortable, but we were able to take pillows and stuff like that and stuff them, so it made it a little bit more comfortable.
We had to use the car seat that they loaned us to feed. We were spoon feed at the time. We had to use it to spoon feed. If it happens, you'll just figure out ways to do it yourself. Like, we ended up having to take an empty white box to put under to brace her up so high to make her more comfortable.
And I actually recently took my daughter back to her daycare just to play with her friends, and I thought, oh gosh, they're all going to be asking questions, what's wrong with her? Not one child acted different around her or asked her what's wrong, which I was very, obviously very happy about, because I thought I was going to have to, explain to them why she was laying down and not really playing and not sitting properly, and not one of them even seemed to be bothered by it, so that made me way more comforted than I was thinking. I mean, every day is a new day, so I mean, if you're probably going to have a bad day, it's going to happen, and you just don't worry about it, because the next day will be probably okay. And there might be a few in there that, the first week I think is probably the hardest week, but we went 3 months in a cast, and that time just flew by, and it's because you just took every day, and most days were just fine, so I think it makes it a lot easier.
So for parents, if you're looking to have some support from other parents, we have what's called the Tennessee Voices, which is a parent-to-parent referral program that child life specialists can refer you to.
We found it later than we wanted to, and her having both hips out, how is that going to be? And talking to, actually one of the parents who went through exactly what I did, really, and her daughter was about a year ahead of mine, and she was diagnosed about the same time, and so it really made me comforted to know that, okay, there's another mom, there's other parents out there that are going through the exact same thing as me, and they're okay, and their child's okay, and they're doing great, and so it really was very comforting. From what I've talked to many kids who've had hip dysplasia, they're the same. Their attitudes just, like a lot of parents, I think that's what they fear the most. Within a few days, she just learned to cope, and now she is doing an army crawl, which she did in her previous cast, and she stands up. She thinks that's great. She actually will yell for us when she stands because she wants us to see her, and her spirit has not changed at all, which is amazing.